Dear ladies and gentlemen, my name is Nicholas Di Gregorio and I'm a gynecologic oncologist at the Department of Obstetrics and Gynecology at the University of Ulm. The next lecture you will listen to is on ovarian cancer. Have fun. Ladies and gentlemen, good morning or whatever time of the day it is you're watching this video. This next lecture in the Advanced Oncology course deals with ovarian cancer. We will start with some information on incidence and risk factors, then take a look at screening and prognostic factors before going on to discuss the diagnostic workup and treatment. In this revised version of the lecture, the sections surgical treatment and systemic therapy are largely expanded. In addition, a new section, borderline ovarian tumors, was included to reflect some new available data. Ovarian cancer is a gynecological malignancy with a worse prognosis. Also, there has been a definite progress in its treatment in recent years. The disease is still fatal in the majority of patients. The main reason for this is that we do not have an effective screening method and are thus unable to detect the disease at an early stage. The one factor which we can, however, influence is the primary operation, as R0 resection decisively improves the prognosis. The graph on your right-hand side shows you the pooled data of several AGO and GINECO trials. Even in a study patient population, which tends to have a rather favorable prognosis, the 5-year survival rate is only 38%. The other message you can read out of this graph is that the majority of patients relapse within the first 2 years after diagnosis. The median age at first diagnosis is about 63 years. The incidence is about 13 in 100,000. However, there are also patients under 30 years of age. Also, the 5-year survival rate for patients with stage 1 disease is 92%. Stage 3, which is considerably more common, has a survival rate of only 27%. Please see slide 12 for further information on the staging classification. The relative survival rate, that is the survival of cancer patients compared to the normal population, is also worse for ovarian cancer than for other gynecological cancers. The figure of 43% for ovarian cancer is less than half that for breast cancer, which has a relative survival rate of 89%, and also considerably lower than the rate of approximately 68% for cervical cancer. The table on the bottom of the page shows the incidence and survival rate of 3 common gynecologic malignancies for comparison: lung cancer. Let us now look at the risk factors for ovarian cancer. About 10% of all ovarian carcinomas have a genetic cause. In most cases there are BRCA mutations, BRCA1 carrying a considerably higher risk for ovarian cancer than BRCA2. In addition to germline mutation, BRCA mutations are also often found in the tumor cell population, which means that the likelihood of finding a tumor cell with this mutation is relatively high. A further known genetic cause is hereditary non-polyposis colon cancer, which abbreviates HNPCC, which is mainly associated with an increased rate of ovarian cancer. The Li-Fraumeni syndrome comprises several mutations. Women diagnosed with this mutation have a 60% higher lifetime risk of developing ovarian cancer. Bilateral oophorectomy can lower this by 97%, the remaining 3% probably being accounted for by extra-ovarian primary peritoneal carcinomas. Non-genetic causes such as overweight have not been conclusively validated as risk factors for developing ovarian cancer, while the use of oral contraceptives is even considered to be a protective factor. Based on molecular studies and genetic testing, a tumorigenesis model called the two-pathway hypothesis has been proposed first in 2004. There it is proposed that ovarian cancer is divided in 2 subgroups. As you can see in the upper pathway, there's supposed to be an adenoma-carcinoma sequence, similar to other tumors, e.g. colorectal cancer, where normal ovarian tissue slowly progresses over benign lesions, in this case cystadenoma, to pre-malignant lesions like borderline ovarian tumors, and finally to invasive low-grade carcinoma. The other pathway has been subject of much discussion recently. There it is proposed that high-grade ovarian cancer actually originates out of the epithelia of the fallopian tubes. As numerous studies have shown, precursor lesions called serous tubal intraepithelial carcinoma, which abbreviates STIC, S-T-I-C, can be found in the fallopian tubes. Those might implant on the ovarian surface. It remains highly debatable if a link between those two pathways exists, e.g. from low-grade to high-grade carcinoma. The main reason why ovarian cancer is often not detected until it has reached a very advanced stage is that there is no effective screening method for this disease. Several methods have been evaluated for efficacy, but none have been shown to have any proven benefit. Determination of the tumor marker CA-125 in serum is considered to be relatively nonspecific, as various benign diseases in which there is peritoneal involvement can also lead to elevated levels of this marker, e.g. inflammation or endometriosis. Evaluation of the ovaries by transvaginal ultrasound has also been considered as a possible screening method. However, the problem with this is that it also leads to detection of numerous benign findings, which cannot be reliably distinguished from malignant findings without further exploration. As a result, large numbers of women have to undergo surgery for benign findings in order to detect one ovarian carcinoma. Various factors are known to have a negative impact on ovarian cancer patient survival. These include advanced tumor stage, advanced age, and poor general condition. This has to do with the fact that surgery in older patients is often less radical and that these patients therefore have a poorer prognosis. Clear cell and mucinous carcinomas also have a worse prognosis than the more common endometrioid and serous carcinomas. Poor differentiation also worsens the prognosis. The only factor which we can really influence as physicians, and which is therefore the most important prognostic factor, is the residual tumor mass after primary surgery. Factors not yet conclusively shown to have any impact are genome analysis and further biological indicators or biomarkers for cancer. In the next part of the lecture, we will look at the diagnostic workup and staging of ovarian cancer. Unlike endometrial cancer, which makes its presence known very early through postmenopausal bleeding, ovarian cancer rarely has any symptoms. Increased abdominal girth with concomitant weight loss is only found at advanced stages of disease. This can be caused both by tumor masses and by increasing ascites. Patients tend to suffer from constipation and recurrent nausea and vomiting. Pleural effusion can cause shortness of breath, and vaginal bleeding may occur. In addition to the clinical examination with palpation, which plays a leading role, vaginal ultrasound is the most important investigation. The pelvic exam reveals enlarged ovaries which, in contrast to benign findings, are often relatively immobile. In addition, nodular lesions can be palpated in the rectovaginal space. In the vaginal ultrasound exam, morphological features are evaluated as criteria for distinguishing between benign and malignant cysts. These include the presence of septa and/or solid components, the absolute size of the cyst, the number of cysts, and the vascularization shown by Doppler ultrasound examination. In addition, the serum level of the tumor marker CA-125 is determined. High levels of this marker in postmenopausal women suggest a malignant process. This marker is elevated in about 80% of all ovarian cancers. Other less specific tumor markers are CEA, CA99, and CA72.4. The next slide compares different diagnostic modalities. As you can see, transvaginal ultrasound, which abbreviates TVS, is the most sensitive modality with the highest negative predictive value in comparison to magnetic resonance imaging (MRI) and PET, not to speak of TVS being faster and cheaper and without exposing the patient to any radiation. The next 3 slides show various morphological appearances of benign and malignant cysts in vaginal ultrasound. These images also illustrate the dilemma facing us, and the sensitivity for detecting ovarian findings is very high while the specificity is considerably lower. The first slide shows in the upper half a normal ovary with a small follicle in 2 different planes. The 3 images in the bottom row show from left to right a common follicle cyst, a hemorrhagic cyst that can often be found in young women or girls, and something that is called a chocolate cyst, which can be found in patients with endometriosis. Now let's move on to the typical morphology of malignant tumors. The next image shows a mainly solid tumor with ascites at the left-hand margin of the picture. This is highly suspicious for carcinoma. The picture below this shows a mixed mass with cystic and solid components, varying internal structure, thickened septum, and papillary structures at the edge. This is also highly suspicious for malignancy. The third picture shows a predominantly cystic tumors without increased internal vascularization. Also, the septum appears considerably thickened. At one point, this finding is in principle not highly suspicious for malignancy. The last picture shows again a solid tumor and internal vascularization made clearly visible by Doppler ultrasound. This is highly suspicious for malignancy. To demonstrate the clinical presentation of patients with ovarian carcinoma, I will show you 2 intraoperative images of a 55-year-old patient with a large abdominal mass. The upper one shows the typical presentation on clinical examination, a cachectic patient with a distended abdomen, which often represents a large amount of ascites. The next image shows the ascites after laparotomy. There's a huge tumor mass originating from the right ovary. Please do note that the tumor surface in this case is rather smooth, which is not quite typical for ovarian carcinoma. The next picture shows massive peritoneal carcinosis on the small bowel mesenterium. Let's just intervene with a small exercise. How would you treat this patient? More than one answer can be correct, and after this part of the lecture you should be able to elaborate on each answer.